Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 239 of our pharmacotherapy series, which majors in CNS infections. The first question reads, KAL, a 58-year-old man with a long history of alcohol abuse, is admitted to the emergency department febrile and unresponsive. During the past several days, KAL has experienced intermittent episodes of fever, chills, shortness of breath, and a worsening productive cough. A friend visiting KAL called 911 when he could not arouse him. KAL's medical records indicate that he has hypertension, adult-onset diabetes mellitus, peptic ulcer disease, and chronic obstructive pulmonary disease, abbreviated as COPD. A splenectomy was performed 10 years ago after trauma to the abdomen. KAL is divorced and lives alone in a low-income apartment. He has no known drug allergies. His records show him to be a smoker for more than 30 years. Current medications include hydrochlorothiazide 50 mg every other day, glipizide 5 mg orally twice daily, famotidine 20 mg orally every bedtime, and doxycycline orally twice daily as needed for cough and increased sputum production. On admission to the emergency department, KAL had a temperature of 40 degrees Celsius, blood pressure of 90 systolic 50 diastolic, and pulse and respiratory rates of 115 beats per minute and 25 breaths per minute, respectively. His weight is 59 kilograms. KAL was unresponsive but withdrew all extremities to painful stimuli. His pupils were equal and sluggishly reactive to light, papilledema and evidence of meningismus were present. Wheezes and crackles were heard throughout both lung fields, with dense consolidation noted in the left lower lobe. The remainder of his physical examination was non-contributory. His stat laboratory tests revealed the following. WBC count of 18,000 cells per microliter, with 80% PMNs, 15% bands, 3% lymphocytes, and 2% basophils. Hemoglobin of 10.5 grams per deciliter. Hematocrit of 34%. Platelet count of 250,000 per microliter. Potassium levels of 3.0 milliequivalents per liter. Glucose levels of 250 mg per deciliter. AST of 190 mg per deciliter. ALT of 140 mg per deciliter. BUN of 35 mg per deciliter. Serum creatinine of 2.4 mg per deciliter. The prothrombin time was high normal, and albumin was 3.1 mg per deciliter. A stat blood alcohol level of 100 mg per deciliter was reported, and a urine toxicology screen was negative. KAL's serum theophylline concentration was 18 mg per deciliter. Stool GWAIC was positive. A CT scan showed no evidence of mass lesions or cerebral hematoma. Lumbar puncture yielded the following results. CSF opening pressure, 200 mm of mercury. Protein of 120 mg per deciliter. Glucose levels of 100 mg per deciliter. WBC count of 8,500 cells per microliter, with 92% PMNs, 4% monohistiocytes, and 4% lymphocytes. RBC count of 400 per microliter. Gram-positive, lancet-shaped diplococci were visible on CSF gram stain. In addition, a sputum gram stain revealed numerous WBCs, few epithelial cells, and numerous gram-positive cocci in pairs and in short chains. Blood, CSF, urine, and sputum cultures are pending. What are the clinical and laboratory features of pneumococcal meningitis? What features of pneumococcal meningitis are present in KAL? KAL presents to the emergency department with many signs and symptoms suggestive of pneumococcal meningitis. He is 56 years of age, and Streptococcus pneumoniae is the most common bacterial etiology for meningitis in adults above 30 years of age. As is evidenced by KAL's presentation, invasive pneumococcal disease often is associated with significant morbidity, and mortality rates remain high. However, likely due to the introduction of conjugate vaccines, the incidence of Streptococcus pneumoniae meningitis in the United States has significantly decreased, from 0.8 cases per 100,000 people in 1997 to 0.3 per 100,000 in 2010. Predisposing factors to invasive pneumococcal disease include advanced age, cigarette smoking, alcoholism, diabetes mellitus, chronic pulmonary disease, and functional, sickle cell disease, or anatomic, splenectomy, asplenia. In addition, individuals infected with the human immunodeficiency virus or with other immunocompromising conditions, such as solid organ or bone marrow transplantation, are at higher risk. Patients with CSF otorrhea or rhinorrhea induced by closed-head trauma or neurosurgical procedures are more susceptible to develop pneumococcal meningitis as well. KAL has many predisposing factors for pneumococcal meningitis. He smokes, has a long history of alcohol abuse, has had a splenectomy, and has diabetes and COPD. The diagnosis of pneumococcal meningitis in KAL is supported by the high fever, stiff neck that is meningismus, and altered mental status. He is unresponsive, which is a definite negative prognostic factor. Results from CSF chemistries and microbiologic analysis are highly suggestive of pneumococcal meningitis. KAL has an elevated opening CSF pressure and a markedly elevated CSF protein and WBC count with a predominance of neutrophils on differential examination. The normal CSF glucose level, that is 100 grams per deciliter, is misleading because KAL is diabetic. The calculated ratio of CSF to serum glucose for KAL is less than 50%, which is consistent with acute bacterial meningitis. The presence of gram-positive, lancet-shaped diplococci in pairs on the CSF gram stain strongly supports the diagnosis of pneumococcal disease. The signs and symptoms of pneumococcal pneumonia, such as cough, shortness of breath, increased sputum production, and pulmonary consolidation, as well as the sputum gram stain result, also lend support to a diagnosis of invasive pneumococcal infection. The next question reads, what would be appropriate therapy for KAL? Resistance among pneumococci to penicillin G, with an MIC equal to or more than 0.12 micrograms per milliliter, is a significant concern. In a surveillance study from 2006 to 2007, 27.5% of Streptococcus pneumoniae isolates from patients with meningitis were resistant to penicillin. Streptococcus pneumoniae strains in CSF with MIC above 0.5 micrograms per milliliter to cefotaxime or ceftriaxone are intermediate, that is 1 microgram per milliliter, or resistant, that is equal to or above 2 micrograms per milliliter. Reduced activity of ceftriaxone and cefotaxime against penicillin-resistant pneumococci affects the therapeutic ratio achieved in CSF and has been associated with clinical failure. Optimal therapy for fully penicillin-resistant pneumococcal meningitis should include vancomycin. The combination of vancomycin and ceftriaxone was superior to either agent given alone in a rabbit model of penicillin-resistant pneumococcal meningitis. Ceftriaxone or vancomycin combined with rifampin also may be superior to either drug given alone. With its potent pneumococcal activity and satisfactory CNS penetration, moxifloxacin may be an option for pneumococcal meningitis caused by penicillin and ceftriaxone-resistant isolates. However, clinical data supporting the use of moxifloxacin in this scenario are lacking. Thus, until more information is available, the combination of ceftriaxone or cefotaxime with vancomycin represents the most reasonable approach to empiric therapy for potential penicillin-resistant pneumococcal meningitis. Until culture and susceptibility results are available, the recommended antibiotic in this situation is ceftriaxone 2 grams given IV every 12 hours and vancomycin 30 to 45 milligrams per kilogram per day IV divided every 8 to 12 hours. KAL weighs 59 kilograms, and because his renal function is not normal, his serum creatinine is 2.4 milligrams per deciliter. His creatinine clearance is 30 milliliters per minute. A dosage adjustment was made. The next question reads, should KAL receive corticosteroid therapy in addition to his antibiotic therapy? KAL presents with profoundly altered mental status, and his signs and symptoms are consistent with a fulminant course of disease. His age, underlying medical problems, likely streptococcal meningitis, and deteriorating clinical status all point to a poor prognosis and argue for the use of adjunctive dexamethasone. On the other hand, KAL is diabetic and has an elevated glucose concentration. He also has peptic ulcer disease, which may be active given that he is anemic and has a positive stool Guaiac result. High-dose dexamethasone therapy may impact upon his mental status, making assessment even more difficult. Although each of these issues is a concern, none is so critical as to preclude the use of corticosteroids. Therefore, dexamethasone given in a dosage of 10 mg IV every 6 hours could be instituted before starting ceftriaxone therapy provided that the diagnosis of bacterial meningitis is confirmed. Dexamethasone can be continued for up to 4 days if Streptococcus pneumoniae is found to be the causative pathogen. Dexamethasone may be discontinued if Streptococcus pneumoniae is not the causative pathogen. To control blood glucose, a sliding scale dosing schedule of regular insulin is recommended. KAL's peptic ulcer disease should be properly worked up and treated if necessary. The next question reads, results from KAL's CSF, blood, and sputum cultures are available and are positive for Streptococcus pneumoniae at each site. Sensitivity testing in CSF revealed an MIC of 0.06 micrograms per milliliter to penicillin, 0.25 micrograms per milliliter to cefotaxime and ceftriaxone, and 0.25 micrograms per milliliter to vancomycin. So my question to you is, what therapy is indicated for KAL? KAL is infected with a strain of Streptococcus pneumoniae that is susceptible to penicillin G. The dosage usually is 24 million units per day in adults with normal renal function. KAL has renal impairment, however, which means he should receive a reduced penicillin dosage. For KAL, who has a calculated creatinine clearance of approximately 28 ml per minute according to the method of Cockcroft and Gault, the daily dose would be 12 to 16 million units, or 3 to 4 million units every 6 hours. This revised regimen should provide penicillin serum concentrations similar to those achieved with high-dose therapy when kidney function is normal. Failure to adjust the dosage appropriately is equivalent to providing massive doses of penicillin, and seizures may result. In patients unable to tolerate penicillin G, the best alternatives are ceftriaxone or cefotaxime. The next question reads, SRR, a 40-year-old, 80-kilogram man, is admitted to the hospital for a cervical laminectomy with vertebral fusion. His surgical procedure was complicated by a dural tear. On the third postoperative day, drainage at his surgical excision site was noted, and SRR was febrile to 38.2 degrees Celsius. A gram stain of the drainage revealed few gram-positive cocci and moderate gram-negative bacilli. Therapy with IV cefazolin 1 gram every 8 hours was begun. The following morning, SRR was oriented to person, place, and time, but he was slightly obtunded and had a temperature of 40 degrees Celsius. Neck stiffness could not be assessed because of his recent surgery. A magnetic resonance imaging, abbreviated as MRI, scan of the head and neck was negative, and lumbar puncture yielded the following CSF results: WBC count, 3,000 cells per microliter, with 95% PMNS. Glucose levels of 20 mg per deciliter. Protein of 280 mg per deciliter. So my question to you is, what important clinical and laboratory features of gram-negative bacillary meningitis are manifested in SRR? Let's first discuss the epidemiology. SRR has developed gram-negative meningitis as a complication of his recent neurosurgical procedure. Gram-negative organisms are important pathogens, particularly after neurosurgical procedures such as craniotomy. Historically, mortality rates from gram-negative bacillary meningitis have been extremely high, ranging from 40% to 70%. With the availability of third-generation cephalosporins, some studies report fatalities have declined to below 40%. However, a recent study of 40 adults with spontaneous gram-negative meningitis reported a mortality rate of 53%. Increasing resistance among certain gram-negative bacilli, such as Enterobacter species and Pseudomonas aeruginosa, presents a therapeutic dilemma in that mortality associated with these pathogens is high and therapeutic options are fewer. We will now look at the predisposing factors. Individuals at greatest risk for gram-negative bacillary meningitis include neonates, the elderly, patients with underlying conditions such as diabetes mellitus or malignancy, patients with open trauma to the head, and individuals such as SRR undergoing neurosurgical procedures. Although meningitis is a rare complication of clean neurosurgical procedures, e.g., craniotomy, or laminectomy, the consequences can be devastating when it does happen. Regarding the microbiology, Escherichia coli and Klebsiella pneumoniae have historically been the most common gram-negative bacteria causing meningitis. However, rates of pseudomonal meningitis appear to be increasing. Escherichia coli is the most common gram-negative cause of neonatal meningitis, whereas Klebsiella pneumoniae is isolated more often in the elderly population. The remaining cases are generally divided evenly among Proteus, Serratia, Enterobacter, Citrobacter, Pseudomonas, and other less common bacilli. Next we will discuss the clinical features. In general, clinical laboratory features of gram-negative bacillary meningitis are similar to other types of bacterial meningitis. Because of high virulence, gram-negative bacillary meningitis often is a fulminant, rapidly progressive disease. An exception to this rule is meningitis after neurosurgery. As is evidenced by SRR's clinical presentation, post-neurosurgical gram-negative bacillary meningitis can present in a more subtle fashion. In such patients, many of the symptoms of meningitis, e.g., altered mental status, and stiff neck, are masked by underlying neurologic disease. Thus, a high index of suspicion is warranted in the post-surgical setting. In addition to gram-negative bacilli, staphylococci also are associated with post-neurosurgical meningitis. The presence of what looks like staphylococci on SRR's wound drainage fluid is of concern, but the abundance of gram-negative rods on his CSF gram stains supports the latter as being the most likely causative pathogen. The next question reads, what empiric therapy is appropriate for SRR at this time? Fewer choices are available for treatment of gram-negative bacillary meningitis than for other meningitides. Ampicillin is active against only Escherichia coli, Proteus mirabilis, and Salmonella species, but resistance has essentially eliminated its use. Aminoglycosides are limited by their inability to achieve therapeutic CSF concentrations, as well as reduced activity in the acidic milieu of purulent CSF. Intraventricular administration, which results in therapeutic CSF concentrations, is usually reserved for difficult-to-eradicate shunt infections in combination with IV therapy because of the absence of data supporting their use. Unlike intraventricular administration, intralumbar injections will not result in therapeutic CSF concentrations in the ventricle. Empiric antimicrobial regimens should include an agent with activity against Pseudomonas aeruginosa in patients with penetrating head trauma, a CSF shunt, or in patients who recently underwent a neurosurgical procedure. Because SRR recently had a neurosurgical procedure, his empiric therapy should include an anti-pseudomonal agent such as cefepime, ceftazidime, or meropenem. Cefepime has excellent activity against Escherichia coli and Klebsiella pneumoniae and is active against other enteric gram-negative bacilli as well. Resistance to third-generation cephalosporins among Enterobacter, Citrobacter, and Serratia is so prevalent that these agents cannot be relied on for the treatment of meningitis caused by these pathogens. With this in mind, therapy of gram-negative meningitis in situations where third-generation cephalosporin resistance is likely, e.g., nosocomial or post-neurosurgical meningitis, should result in the use of cefepime or meropenem. If a pathogen is isolated, therapy may be tailored based on culture results, antibiotic sensitivities, and antibiotic penetration into the CNS. For example, success rates exceed 80% with cefotaxime and ceftriaxone for gram-negative bacillary meningitis caused by Escherichia coli or Klebsiella pneumoniae. For SRR, cefazolin should be discontinued, and treatment with cefepime adjusted for renal insufficiency, that is, 2 grams IV every 8 hours, should be instituted until the return of culture and sensitivities. The next question reads, culture results from SRR's wound drainage and CSF both are positive for Enterobacter cloaca. Sensitivity data reveal resistance to ceftriaxone, cefepime, ceftazidime, piperacillin tazobactam, and aztreonam. Drugs to which the isolate is sensitive include imipenem, cilastatin, meropenem, TMPSMX, gentamicin, tobramycin, and ciprofloxacin. So my question to you is, what alteration in antimicrobial therapy is most appropriate for SRR at this time? Citrobacter species presents a particular challenge. Furthermore, some isolates that are sensitive to third-generation cephalosporins can become resistant during therapy by virtue of selecting for derepressed mutants. Thus, in contrast to gram-negative bacillary meningitis caused by Escherichia coli and Klebsiella species, alternative therapies are needed when treating meningitis caused by Enterobacter, Serratia, Citrobacter, and Pseudomonas species. The isolate is sensitive to imipenem C. listatin, but the higher propensity for seizures compared with other beta-lactams, including penicillin G, argues against its use in SRR. Meropenem is not considered to be epileptogenic and should be used preferentially to imipenem C. listatin for meningitis. Clinical trials have evaluated the efficacy and safety of meropenem versus cefotaxime in the treatment of meningitis in children. Clinical outcomes were similar among the patients randomized to either group, and the incidence of seizures was similar in the treatment groups. Thus, after consideration of the aforementioned options, meropenem appears to be the best choice of therapy for SRR and carries FDA Food and Drug Administration approval for this indication. However, TMP-SMX, although not FDA approved, may be an option as well. Cefepime should be discontinued and, if confirmed to be susceptible, therapy started with meropenem 2 grams IV every 8 hours adjusted for renal insufficiency. Next we will look at duration of therapy. The optimal duration of therapy for gram-negative bacillary meningitis has not been clearly established. Because of the high mortality and morbidity associated with these pathogens and the reduced susceptibility of enteric pathogens to antimicrobial agents, 21 days has been suggested and should be provided for SRR. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 240.